Yeah, so hi, I'm Joe Davis, Associate Director, Commissioning Performance and Intelligence at Royal Cornwall Hospitals, and I led the Cornwall Analytical System response to COVID. So thanks to those of you who stuck this out to the end. I know it's the ultimate graveyard slot, isn't it? We've got the last one of the day, some quite interesting presentations opposite this as well. So, and also it's a tough gig harking back to the pandemic when it's been a long day and the bar's calling. I totally get that. So thanks for staying with us. So, as you'll all hopefully be aware, this is about the system intelligence response in Cornwall during COVID and how we developed what we developed was used in practice in the health and care system. And I should also say that the tone of it is by nature quite positive. And in that, I recognise the awful nature of the pandemic for so many people in their personal and professional lives. So I'm just mindful of that. So I don't normally put myself or people in Cornwall up for presentations like this. So several reasons I have this time. Recognising that similar exceptional work was done in many places during COVID. Partly I wanted to acknowledge and pay specific tribute to the work that our teams did, partly because I think it's important we don't forget what we learned and to also to analyse why it worked. So obviously some parts of the pandemic, notably the sort of sweep everything away and just focus on this, the sense of mission and urgency, the novelty of it, you can't replicate those or assimilate them fully into normal working life. But I think it is still worth reflecting on what we can learn from the period, especially in the context of the broader lessons for analytics and the conference theme of analysts as influencers. So in terms of the presentation, I've stuck to the discipline of the abstract. So why we set out to do what we were doing, what we did, how we did it, what was the result, and what are the learning points. Thank you. So first, why we did what we did. So that's pretty easy generally, because in the early stages of the pandemic, there was a shortage of intelligence that people could really rely on, and of course, a major hunger for it. I expect that everybody has reasons for why local dynamics made things a bit different for them during the pandemic context. And for us in Cornwall, there were two main things, one good thing and one bad thing, if you like. So we were fortunate in most variant-driven waves in that we tended to get them relatively late. So we had a little bit of warning of what to expect before it happened. And that was in itself a challenge because it meant our tools had to be capable of being changed really quickly. So we didn't have time to do much with them. You had a week kind of thing. So in turn, that meant they needed to be really simple. But overall, it was an opportunity because we did get a bit of advance warning of what was coming before it did. And we got a clear sense of that really early. You can see the bottom left-hand chart there, where we had to take probably what was our most courageous call of the pandemic in terms of telling people that the first wave had probably already peaked, when that very much wasn't the sort of mood music that was around at the time. In terms of more challenging local factors, that would be the impact of tourism, and especially memorably the G7 summit in June 2021. But overall, the Cornwall specific factors meant that nationally generated info, which only went down to a regional level, wasn't all that much use to us a lot of the time, because it was too positive during the summer and too negative when waves started, basically. So that's why we did. So moving on to what we did, both in terms of what we produced and how we communicated it, because both are key things to influencing. So thank you, next slide, please. So we developed loads during COVID, but a few particular operational tools stand out, which were largely developed in-house by our fantastic analytical teams in Cornwall. We're really lucky across the system to have some amazing and committed analysts who did some really good work across the system. And throughout, we've tried to stay on the front foot in terms of working with the frontline teams to try to work out what they would want to know and then trying to do that. So firstly, we developed a live COVID dash with patient drill through links to the lab data in the acute. And we've got plenty of experience of working with live data. We concluded early on that some kind of live summary dashboard, which would be up in our control center, was a must. And with pretty much round the clock work with all concerned, we got that up and running before the end of March 2020. It's still going now. We prioritised time early on bringing in the lab data and the information relating to critical care. And the combination of all those things has really helped us with time later as we've needed to build them into national reporting tools and things like that. I've shown you here a couple of the tools we've had at various points. So covering aspects like inpatient vaccination status, time of onset from admission in the bottom left-hand corner, oxygen levels, whatever's been needed at the time, really. Thank you. And we also developed a range of modelling and predictive tools. And these have varied quite a bit in terms of who does them and how good they've been as the available intel has waxed and waned. So at their peak during, say, autumn 2020 to spring 2022, when the information sources were really good, there was lots of testing, we had advanced warning of how variants were going to behave. Our tools were really accurate, actually. And that was great, although it's caused some issues over the last year, getting people used to the idea that those days are gone now, because the data's gone. So we don't really know what's happening anymore. But in the early days, in terms of who helped us with that, we had a lot of incredibly helpful support from the University of Exeter Maths Department for the development of a general COVID case and hospitalisation tool, which we were able to use to adjust for the impact of tourism. And we were able to bring that in-house later on. We were also able to do some really good short-term modelling. You can see that in the bottom left-hand corner, And what we were able to do there was we were able to get live case data via the public health team and effectively live hospitalisation rate data from the national COVID dashboard and splice them together to give a really kind of relatively accurate view of how many hospitalisations to expect over the next week. We were able to use that to develop estimates of the likely impact on other services, community services, GP practices, and so on. And doing all that modelling work ourselves also meant we were able to unpick the assumptions on it in quite a lot of detail, and people seem to appreciate that. We developed a COVID alert system as well, with the help of the ICB team, which basically, it was on the top left of the previous slide, don't bother going down though. And that smashed together a load of indicators into an index which we linked to the government's 5-level approach. So we used that to estimate a Cornwall-specific R rate and prevalence. And again, at its peak, that was a really good tool as well. But we've also done a load of other things. So we've used a whole new range of data sources for data and intelligence, which has been key to lots of our developments. So we've been able to work with public health really well in a way that perhaps we haven't before. And that's generally meant that both sides have had access to a load of different data sources we wouldn't normally get. We use Twitter a lot for a combination of prevalence type information and modelling intel and things. And that's also been brilliant for periods where things are changing rapidly. For instance, when Omicron was starting in South Africa, trying to work out what was going on there, as well as having some of the best info available on important questions like case ascertainment. And sorry, can we go back to the other one? And in terms of the way we worked in Cornwall, it really did feel as though we were working as one team across the system. We were able to minimise IG constraints and organisational boundaries in a way that we haven't really been able to before or since. And we were able to relate or directly link up system data in new ways, like 111 data to ED attendances and things like that. And we had some really productive relationships around the broader patch, particularly with Devon, which we were able to use to sense check our modelling. But I think one of the really most significant changes was how we communicated, which changed massively, and I think for the better. So very early on in the pandemic, we developed a kind of week in COVID analysis pack, which we've maintained between a few of us across the relevant analytical and performance teams across the system. So the contents have evolved a bit. The summary slide gives you a rough idea of what's in it. And we set up a weekly 30-minute team session to go through it and communicated both the team sessions and the slides to a wide range of people across the system without asking anyone for approval to do any of that first. And we also supplemented that as the pandemic progressed with some live events covering all the staff in the NHS and the local council, covering all staff both in the NHS and the council, going through the local modelling and what was going to happen next. And during the peak periods, we had about 150 people joining the weekly presentations. We had about 500 or so join the episodic staff ones. And that all generated more interest. So we were asked to present to all kinds of different forums from the PCNs to the Cornish MPs. And that's quite a big change because in the past, you send your slides, you go to the meeting, you get 2 minutes because the previous item overruns. You don't get the time you need. If you present it yourself on your own terms, then whoever joins it are the right people and they want to hear it. And the flexibility of that weekly analysis and the presentation where we own the content has meant that we've been able to flex it as things have evolved and got more or less useful over time. And that's definitely been more labour intensive than just chucking together a few dashboards would have been. But I think the effort has been worth it in terms of building the overall collective knowledge and understanding what's going on in the system. Thank you. So in terms of results, we've included that the modelling products have been directly used to operationally plan. So we've used them at times to say, we're going to need another ward next week. We're going to be able to take it out in 3 weeks' time. We've used it to inform the maximum service capacity levels planned for across the community. The skills of the teams have really increased and their ability and comfort with dealing with adapting information from a wide range of different sources. And we've had a real breakthrough, I think, with operational research tools and the hunger for their use. And we have a load of stuff live now in terms of now casting and urgent care alert system and stuff, which is built on the work we used during the pandemic and the skills that people developed there. And we've been able to develop some of that into day-to-day system working. And I think we increased our own autonomy because there was more of an expectation that we produce and communicate things ourselves rather than waiting for other people to do it for us. And we found that doing that has kind of democratized the information a bit. So often those of you who work in NHS Trust know that often the data can be quite sort of regimented in terms of how it's managed, messages communicated and things like that. And being a bit more freewheeling about that during the pandemic was quite energizing for lots of people. And that's led to a positive impact on relationships too. So we've had loads of positive feedback on all aspects of this work, almost universally. And we've had our best staff survey results ever in our teams, including results in our acute trust that have been better than the best trust level score in the country on every domain. So finally, what have been our key lessons? So Firstly, the importance of balancing timeliness and accuracy when producing tools. I mean, the guy who was doing the thing in the lecture theatre would have a fit, I think, with some of the things that we did during the pandemic. But if you've only got 4 or 5 days to do it, and the choice is that or nothing, then maybe you go with that. So it's always a balance, isn't it? And I think all of us, especially in heads of department roles, grapple with that, because analytical roles often attract people. They want to take the time. They want to get things right. They hate things going out if they might be wrong. So it's a balance, isn't it? Sometimes accepting things are good enough is difficult for people. It's also hard to let kind of lovingly curated things that you spent ages develop go when they're not useful anymore. That can be difficult too. So the importance of prioritising things that can be practically used rather than things that are technically interesting to develop. Another key challenge in analytics, and something that we need to be overtly balancing those questions of technical interest to produce versus timeliness versus ongoing operational usefulness in the way we do things. And in order to keep doing that, the only way you can do it effectively is by challenging yourself to keep your noses to the ground in terms of what people actually want to know, and developing our collective skills so that we can communicate to people in the language that they want to hear it rather than the language we want to communicate it to them in. And that's not always a valued skill, I don't think, in healthcare analysis. That go-between role between service and analytical teams is critical to the success of that. How do we build alliances with people with those skills in other teams too, and get them on board in terms of communicating the messages that we need them to be communicating? And I think we're always looking for those people who've got that triangle of a sort of sense of purpose, a reason to be in healthcare with that technical expertise and the interpersonal skills to do that. And it's on us to adapt our comm skills to the people we're communicating with. System working, when we actually do it, is really energizing, and one of the great features for me of work during the pandemic, not just managing bureaucratic IG processes, but it was great and lots to learn from each other, especially our public health colleagues. And that was a really, when the relationship increased so suddenly in importance, that was a great feature of the pandemic in terms of our working. Democratization of information, both locally and nationally. And I think pragmatically, the more people you can get the analysis to, the more people are likely to do useful things with it. So we've got the brains behind the COVID dashboard coming tomorrow, haven't we? And speaking to us. And I think that's a great example of when the data is just put out there, other people can take it, download it, run with it, do useful things with it that we can all learn from. They don't necessarily see that, but it's really useful rather than just putting something up that you have to snip everything out of and all the rest of it. And COVID Twitter, which was generally a wonderful thing for local analytical teams as well. And at its peak, it really helped enable us to predict what would happen locally with a good degree of precision. So how do we, all those things have gone to some extent, how do we replicate some of them in the future in terms of the work we do? And unleashing the power of teams to communicate info on our own terms, that's something which should be here to stay. We should trust people more to use the information responsibly. By and large, they generally do. And as analytical teams, we need to be giving just as much thought as to how we get heard as to what we have to say. And sometimes creating your own rooms can be a useful adjunct to always fighting to try and be in the room where it happened. So in terms of how much we've sustained, some but not all of it, basically. So we still do the weekly data pack. It's now morphed into a kind of SCC, System Urgent Care data pack, but it maintains the sort of system-wide version of the truth point. We've maintained a system approach to quite a lot of our work, but not everything is stuck. So I think our system working overall has weakened a bit. People have become pricklier about organisational messaging again, tighter on comms again, and we haven't got the scale of interested audience that we had during COVID. I think that's clear to say. But in general, I think it's been a hugely positive and rewarding period. We've improved as analytical teams in terms of our skills and ability to influence, and we need to build on that, paying just as much attention as to how we get what we produce used as to what we develop. And thank you for listening, everybody. And thanks for sticking with it. Happy to take any questions from anybody already.
Thank you, Joe. There's so much of what you're saying that just resonated with our experience and our observations during that period as well. And just to go back to where you began, it was kind of grimly positive for analytics, wasn't it? This period. I mean, there was just this horror, but there was so much positivity from the analytical community in terms of its response and the use and all the rest of it. We don't have long for questions, but maybe I could let.
Quick one, Joe. Thanks for that. How much of that stuck? I mean, it's a big silver lining. That's the thing about now communities got to show his work and everything, and being listened to a little bit. How much of that now that they're not a distant memory, but
Well, COVID analytics itself has effectively completely gone because there's, in my view, because there's just nothing useful out there now, pretty much. However, the things that have stuck, I think, are the closer system working, the sort of knowledge of what is possible to do in a short period of time, I think. Teams and the communication of it, and the ability to just, if you think you've got something interesting to say, just put in a Teams meeting, invite whoever you want. No one in practice stops you.
Too much more,
Well, yeah, I think so. I mean, not as much as during the pandemic, but more than we did before, perhaps. But I think as well, you are fighting against a bit of a kind of splintering process, I think, going on in terms of things reverting back more to where they were before as well. And as I say, the operational research side as well, that progress has stuck, and people's familiarity with an expectation of actually. So when flu hit last year, there was an expectation that we would be able to do something rapidly, like we were able to do with COVID. And actually, we found we were. It was, we had the skills to do it. We were able to get something useful up and running pretty quickly. So yeah, some but not all.
Let me bring this to a close. I've let us run over. One thing that we found has lasted from that was the kind of networking effect and the ability to convene people quickly and getting analysts work together and focus together and network. And my guess is that would be durable.